everyone to ASJ GEMS Global Educational Meetings. I'm your moderator, Phaedra Kress, and I'm here with the one and only Dr. Chachi Kao, who will be presenting the Ponytail Facelift Breakdown today. It's my pleasure to welcome you. Dr. Kao is a board-certified plastic and reconstructive surgeon and founder of the Kao Institute in Santa Monica, California. With more than 2 decades of experience, he is internationally recognized as the creator of the Ponytail Facelift, a groundbreaking facial rejuvenation technique, which we'll be learning more about today. He earned his medical degree from the University of Washington and completed both a 5-year general surgery residency and a 3-year plastic surgery residency at the University of Southern California. Today, he's an active member of leading societies such as the Aesthetic Society, an ASJ author, and a sought-after educator, training surgeons worldwide in his innovative methods. Please join me in welcoming Dr. Kao.
Thank you very much. Can you hear me okay?
Yep, perfect.
Okay, so today I want to present something that's stems out of the ASJ paper. And I thought I'd do something different. Instead of rehashing the paper, I wanted to take a look-like surgery that we filmed for this. I want to break it down to each steps similar to the paper. So we're going to have illustration and then followed by video that look like format. So that's what I wanted to present today. So we have a patient here that we're going to present here.
So when you look at me, what bothers
Can
you?
you hear that okay?
Here, I try not to look in the mirror. Okay, here. You know, this line used to be a lot worse 20 years ago. I had a huge line here because I always did this. So throughout all these years, it came back again.
So she's, I think she's 58 years old, and she just complains of sort of tired-looking eyes. The main problems in the jowls and the mid-face area, and also in the neck. The neck is
Okay, so we're all marked up. Eyelids centrally, we're gonna leave this about 10 millimeter and then 5 millimeters in the corners. Do some fat grafting up here, the temple area, forehead area, like this area, and then a little fat grafting along the lower eyelid cheek junction. Biggest problem is the cheeks, a lot of mass here. She's got deep nasal little folds, like kind of folds over here. And I figure what to do with that little fold over here, right around the base of the nose. And then augment this bone. This is a lot of bulk right here and here. We're gonna have to thin out the lower face area, here and here. Go ahead and flex your neck. Just platysma bands are quite strong. Relax. Do it again. Okay, so we're gonna have to address those things here. And then the neck laxity goes all the way out to the clavicle area. We're gonna get rid of all this neck skin here. And then on this side, look down, looser on this side. Goes all the way down the clavicle, lower face area, and then we have our glands hanging down. Okay? All right, are you ready? Okay.
So this is fairly typical 58 years old woman, you know, sagging jowls and the neck is a lot of neck laxity, the mid-face ptosis, upper eyelid blepharochalasis, lower eyelid laxity and redundancy. So this is fairly typical of aging patients, and we're planning to appoint a facelift and without preauricular incision. So we're going to do upper and lower blepharoplasty, a mid-face lift, a jaw lift, and resection of skin and neck. And we're going to do a deep neck contouring with reduction of subendyral glands and the fat transfer. So we're going to start with upper blepharoplasty. So the patient was marked in a sitting position, and the amount of skin we take is actually is really kind of conservative because we don't want to, we mark the patient upright and also we sort of modulate the amount of brow modification we're going to have so we can limit the lateral extent of the incision. So we're taking just skin, and leaving the muscle, preserving the orbicular oculi muscle. there like that. Okay. And then we are just going to tease out the medial fat pad here. So we're not resecting a big layers alkali muscle, which is teasing the medial fat pad out just a little bit and just conservatively just resecting that little bit of the excess there. Sometimes we'll do a preservation where we actually transpose the medial fat bag in the centrally if there's an A-frame deformity. She doesn't have that, so we're gonna just simply just sort of contour that a little bit. You see that's a very, very conservative resection. I like to close the upper eyelid in 2 layers and taking a 7-0 vicro suture to close the brickler's alkali muscle. I know a lot of people, they just like to close in a single layer, a suture that remove in 7 days or so. These I like to close in 2 layers so that I can get a little bit better relaxed, little better closure with less tension on the surface of the skin. And this is the sunroll purling. So the lower eyelid, so that was upper eyelid, lower eyelid, we're gonna do a little skin pinch. And it's surprising how much you can actually pinch the skin. And we used 2 forceps, and we're gonna use this is a green fixation forceps here to define where we're gonna pinch, how much we're gonna pinch. And then it's surprising how much skin you can actually remove, so we have to be careful of over resecting. But this is necessary because when we do a good cheek lift, we're gonna gather excess skin in the lower eyelid area, so we absolutely have to remove the little extra because afterwards we'll have accumulated more skin there. So this is almost like a centimeter removal. And then we close the orbicularis oculi first, and then we do a fine closure of the purling suit, but the purling seminal purling suture, and that gets removed in 4 days. Then we're going to start the lower neck dissection now. And the incision just perilobular behind the mastoid area, and then we'll extend it into the hair bearing scalp here. And then we're going to extend
Our subcutaneous dissection here, and here's the platysma. See how loose that is. Okay. So this is subcutaneous dissection.
So the subcutaneous dissection is
Below this
extensive.
line onto the or kind of shear down, taking down the mandibular ligament down, way down to here, back here like this, right? And then
So that's a subcutaneous dissection. This is marked from the line drawn from the ear to the ala of the nose. And then the section is very extensive. Everything below that line is dissected all the way down to the clavicle, taking down the mandibular ligament as well. So you can see in the figure in the ASJ, that's the extent of the subcutaneous dissection. And then this is a deep plane dissection.
platysma, you have deep plane dissection, and it's going to be across about 2 centimeter medial to the edge, anterior border of the masseter, down, and then it's going to be down here, you see, about 4 centimeters down, and 4 or 5 centimeters over.
So that's a deep plane dissection in a subplatysmal and submass level. And that is going to be releasing the fixed mass and then into the mobile mass about 2 centimeter medial to the anterior border of the masseter and extending down below the jawline about 2 to 4 centimeters inferiorly, also about 4 to 5 centimeter medially to mobilize the the lateral platysma muscle. Once that's released, we're gonna just leave that alone. We're gonna go to the central neck here. The incision for the central neck is very small, it's very high in the chin skin. And then the section is very extensive down to the head of the clavicle and extending and communicating with our lateral neck dissection. So everything's freed up. The difference between this dissection and for the central neck is that our incision is very small and very anterior because I don't like that scar showing at all. But it makes the submandibular gland reduction much, much harder. So here we're gonna go under the platysma muscle here. We make an incision in the horizontal fashion in the platysma muscle. Okay, so right now, this gland is about 4.5 centimeters away from the midline, both sides. You can see that this is here. This is the platysma here, with the subplatysma. Here's the digastrics here. And then here's our gland. Right here. That's like right here. And then the gland on the right side is right here. At 4.5 centimeters. So what I'm showing you that her glands are about 4.5 centimeters away from the midline on both sides. And I wanted to show you before I start modifying the digastric and plicating the digastric, see what that effect is on the position of submandibular glands. So we remove the subplatysmal fat, and now we're contouring and shaving us down the digastric muscle. And that figure is from Dr. Andre Arswald in his publication. So we shaved down the digastrics, and now we're going to start plicating the remnants of the digastric. And that first stitch at the very bottom at the tendon of the digastric is very important because we want to make sure we don't take too big of a bite because the hypoglossal nerve is behind the tendon of the digastric. If you take too big of a bite, you may have a problem with the hypoglossal nerve injury, which causes tongue deviation and the ability to speak. So the application and tightening of the remnant of the digastric continued superiorly toward the edge of the incision. So that gets plicated with 4-0 ethibond sutures all the way up in an uninterrupted fashion. So that is the last one. Okay. All right, we'll advance. So once after I plicated the digastrics, these things come in. And now instead of 4.5, it's 3.0 on the left side and 3.5 on the right side. So that's what we measured. So I'm gonna go get these glands. So you see, once we plicate the digastrics, now we have mobilized the glands medially by 1 centimeter and 1.5 centimeters medially to make our resection much easier and more visible, easier to see. So that plication is valuable, especially in our case when our incision is so small, it's through a keyhole incision. So here we are looking at the left submandibular gland here. We're trying to resect. We're dissecting within the capsule, and then go all the way around the gland and resecting the gland. I don't use, there's a gland coming on one piece there, and that's the other side. They are big glands coming on one piece. I don't like to piecemeal it. you'll see the result of deep contouring. Once that's done, we're gonna finish plicating the the closing of the capsule, the remnant of the capsule, and then we're going to oversew the cut edge of the gland, and then we oversewed in a baseball stitch, and then we're gonna run it through the platysma muscle and back down, so we can plicate and plaster that platysma muscle down to the cut edge of the gland, so that try to avoid any problems with sialocele or even bleeding problems. Okay, so the plication of the gland is very important, and that figures is from Andre Arswald's publication. And now the both of the glands has been oversewn and plicated. We're gonna then close and plicate the platysma band centrally. And this is done with, again, multiple interrupted fluoroethibond sutures all the way up to the incision line. When that's completed, we will then also do a back cut very as low as possible, below the cricoid, I'm sorry, the hyoid, and then we can then do a back cut to avoid kind of subsequent banding of the neck muscles. So now then we leave everything alone. Once we've done that dissection, now we're going to go up top and do our endoscopic dissection. So this is the incision in the temporal area. And this is the incision in the perimedian area. The temporal area, the section is between the deep and superficial temporal fascia. And then this, in the perimedian area, is subperiosteal dissection here, the subperiosteal plane. Okay, we're gonna get into the subperiosteal plane right here. You see the bone, and then we're gonna begin our dissection by creating an optical cavity. We're gonna do a lot of posterior dissection, so we'll create a good optical cavity here, popping through the temporal crest area, taking down the superior temporal septum. Okay, and then now we'll get ready for our scope to come in. We're gonna first ligament, we take down the superior temporal septum right here. And that's done endoscopically with a scope in my left hand. And then we're gonna take down the septum with a flat elevator all the way down to the orbital rim. See the orbital rim right here? We're getting close to it. And the section is getting a little tougher here because she has some Botox, repeated Botox work here. And then you'll see we're releasing the periosteum off of the orbital rim here. You'll see the supraorbital artery and nerve to your left. And then you see our dissection. The next ligament we take down is a temporal ligamentous adhesion. And this is a very thick adhesion at the top of the orbital rim. And this is very important to take down entirely, because if you don't, you won't get a good movement of the lateral brow. And this has to be done with the scissors to splay out the tissue in this area in order for the expansion of the brow to elevation of the brow. You see that we have to complete the incision into the periosteum here. Okay. So we're dissecting here. Now we're off the orbital rim here, the periosteum. And then we'll go back to the scissors here, or the elevator. Just make sure that's all coming off of the inner side of the orbital rim. See that? And now that's an adequate release, and also help redrip the upper eyelid skin without actually cutting the upper eyelid skin in a form what we call a non-incisional upper blepharoplasty. You see how we're using the scissors to cut those thick adhesion bands in order for the lower brow, the lateral brow to expand. Here's a supraorbital artery and nerve right here. But continue to span the lateral orbital rim and the temporal ligaments adhesion. So this is absolutely critical for the longevity of the brow rotation. The next ligament we take down is the zygomatic arch ligaments, and this is a very thick, dense area along. This is a superior arch ligament here. So we put a needle right there. So to designate the lateral third of the arch, which is safe, because the medial to that needle, the frontal branch of the facial nerve is coming superficial into the superficial temporal fascia. So here we're going to go through the superior arch here. Right here, you see the superficial temporal vein that's there, which we want to preserve that. And now we're going down almost below the inferior arch that we have marked. And here, then we want to switch planes into a more superficial plane here and connecting with our lower face dissection earlier in the operation. So now we're connected to both dissection areas. And finally, we're going to do the inferior temporal septum. And this is a loose areolar area that the dissection and the scissor spreading is much smaller and more gentler because we have, there's our needle again, this is along the superior arch, because we have to be sure that we don't injure the frontal branch of the facial nerve. And also we have to identify what we call the telephone pole formation, which consisted of a sentinel vein, the medial and lateral zygomatic temporal neurovascular bundle. So this is the little spreading here. You'll see we're just defining the anatomy in a temporal region. So we are looking for the sentinel vein, which is coming up soon. So there's absolutely no cutting here. We're just sort of separating the facial layer in a deep plane. It's the most natural layer without really delaminating the skin, right? So this is a sentinel vein that we have here. We're gonna mark that, the sentinel vein. And then we're going to see the medial lateral zygomatic temporal neurovascular bundle. You see? You see right there? So now the medial lateral zygomatic neurovascular bundle, we're going to dissect around that, and we're going to go through. Okay, before we do that, we're going to take down the lateral orbital thickening a little bit to turn the eyes a little bit so that the eyes can be tilted up slightly. And there's the lateral orbital thickening. We're going to release that just a little bit. So in these areas of these sort of fox eye or tilted almond eyes that people desire, patient desire, we can modulate how much tilting we want by the amount of dissection and the release of the lateral orbital thickening or precanthal ligament. And now we're gonna go, looks like we're going through between the medial and lateral zygomatic temporal neurovascular bundle. We're gonna go into the midface area now through our dissection. And you see that we have the swoop, the orbicularis oculi muscle just above there, okay? We're gonna continue the dissection down. We're gonna map out the course of the zygomaticus major and minor muscle. Here, you see that? And then we're gonna dissect down, continue our dissection down toward the midface. We see a little bit of the zygomaticus major muscle to the right there is to the left. You see to the right, the zygomaticus major muscle right there. And then we're gonna see, we'll continue the dissection. So we don't want to be very lateral. We don't want to be much lateral than that. There's the zygomaticus minor muscle. So we're gonna stay on the medial aspect of the zygomaticus major muscle so that we can protect the zygomatic branch of the facial nerve that sends a little tiny branch to the lower orbicularis oculi muscle. We want to protect that and avoid that nerve so that we can avoid injury to that nerve, which can cause a slow blink or paralysis of eye closure. Okay, so we're going to continue the dissection down through here, and as we come down around the body of the zygoma, we're going to see that we're marking out the nasolabial fold. We're going to come across the nasolabial fold and into the commissure of the mouth and then into the marionette area. So this is not possible if you're doing a subperiosteal dissection here. And this is what we're learning today in our Ponytail Academy here, in our lab here at University of Pittsburgh. And we're showing that, we're demonstrating that technique of really as a preperiosteal dissection in the midface. So our students are observing on Zoom right now. They can just, this is what we just went over. And then so now down here, we are doing a dissection from the upper face to the lower face. Again, connect, actually right here, we're gonna go on the left side and we're gonna go across the nasolabial fold here on the left side as well. Okay, so now both sides have been dissected. The midface has been dissected along the zygomatic major axis, what I call a Z axis of beauty. So everything's gonna be lifted along that axis, which is gonna be lifting at the corner of the brow, the lateral canthal area, the cheeks, the nasolabial fold, the corner of the mouth, and then the marionette area, all in one composite flap. So here we now begin our suspension suture. So suspending here, we're going to first put what I call level 1 suturing. We're going to put that suture into the condensation of that we just took down, the zygomatic arch ligament, the inferior ligament here. We're going to take that down and suture it to the deep temporal fascia. So this is beginning of our fixation. These are cable suture. There are progressive tension sutures. You'll see how we're progressively going to elevate the facial flaps. So this is the first one in the inferior arch area tied to the deep temporal fascia. And this is a very powerful stitch right here. Okay, we tied that down, and our next suture is going to be on the. So this is what we're doing right here. This is going to be the superior arch. This is going to be on a superior arch ligament here that we took down earlier. So we have one in the inferior arch, we're gonna put two in the superior arch. And notice it's all in that little checker box that we drew in a surface landmark in the lateral third of the zygoma to keeping it safe, avoid injury to the frontal branch of the facial nerve. So this is our second stitch right here. All right. So we're gonna tie those two stitches to the deep temporal fascia, further elevating the side of the face in a progressive tension suture. Okay, so we're going to tighten that area. Okay, so tie that down. Okay, now we secure the level one, we call level one suture along the arch now. Okay, so that's one lateral aspect of the fixation. And now we have to go to the cheek fixation. So this is still part of level one. The arch and the cheek is level one. So with this, what we're gonna do here is we're going to first, we're gonna put a stage stitch in the cheeks so we can retract the cheeks. So this is a needle with a little tiny hole in here. We're gonna pass that, pass a little suture through the hole, the needle, and bring it through here. So now we have a little handle on the cheeks to pick up the cheeks, okay? Next, we're gonna tag that. Okay, so this is actually a little different suspension we're using here. So what we're gonna use is a little 4-0 wrestling suture here. We're going to put it back through to suspend the cheeks. I'll show you in a second. So we're going to grab that needle. Let's suspend the cheeks right here. So then we're going to use a little jigsaw motion to pull through that to pick up the cheeks. So this is the situation in this patient that we we normally use the Indotime ribbons. However, the ribbon is not available. It's been back ordered. It's been a problem with the company Micro Air who makes the ribbons. So we have to improvise here with a sort of like a suspension suture with a seesaw in through the skin so we can pick up the cheeks. That's just another method of fixation that we have. There's another one here. We're going to do the same thing here. We're going to poke through. A lot of our colleagues who are taking a course here at the Ponytail Academy, they don't have the Micro Air ribbons available in their country. So this is an option that I'm showing here to be able to lift the cheeks with sutures. Because sometimes to make a stitch, to do an endoscopic stitch from, it could be more difficult for a lot of people. So I'm showing you a different alternative method than the ribbons. And I believe that's an Ethibond suture rather than a Merceling suture. That's an Ethibond suture coming through here. So we have two in the cheeks right there. There's a little bit of dimpling, but you adjust that incision. You sort of seesaw the two sutures together a little bit. It can pull through just a little bit to get rid of that dimple. We want to make sure that the dimple is gone. Okay. So the cheek has been kind of suspended with these two sutures in the cheek malar fat pad here. Okay. So I'm seesawing a little bit back and forth to get rid of that dimple a little bit more. Okay. Then I'm gonna take that suture, I'm gonna bend it back so it's round again. And I'm gonna put it through the deep temporal fascia and fix it to the deep temporal fascia. So many times in surgery, you know, like a good chef, you know, when you don't have the right ingredients to have to make a good soup, we have to improvise a little bit to make things do. In this situation, we didn't have the ribbons available to us, so we're gonna have to use a little different technique. Okay. This is our third suture in the same way. So now we have 3 in the cheeks here to make sure that we have a good grip on the cheeks and elevation of the cheek fat pad. And then everything is fixated on the deep temporal fascia here. Okay. Okay, so those are the 3 in the cheeks. And then now we have other progressive tension suture just in the upper part of the cheeks. So those are in the deeper part of the cheeks, and then we're going to put it in the superficial part of the cheeks. Make sure the cheek comes up smoothly, so there's no indentation or redundancy in the upper part of the cheeks. I'm constantly checking for any kind of laxity and redundancy or dimpling in the cheeks. Obviously, when we have the ribbons is a little easier to do. When we don't have the ribbons, then we have to do something else. Okay, so we're going to tie that down, stabilize the cheeks. Okay, looks like there's still a little bit of laxity there. So we're going to put one more stitch. You see how I kind of figure out where the laxity when the next progressive tension suture is going to be? So that's the, we're going to put that suture again in the upper portion of the, or the lateral cheek area. Okay. Take a little bite in this area, suspending it to the deep temporal fascia. So you can kind of understand the nature and the principle of the progressive tension suture. So there we go. All right. So now that's tied down. So we got our cheek secured and this arch secured. So this is the level 1 suture now that we have completed, just that level. Okay, so looks like we made the temporal incision here, right? And so now we're gonna make a relaxing incision here with a little TPF eyelid. Okay, so this TPF eyelid, if I pull here, is being restricted by the TPF. If I release this relaxing incision here. So this is the temporal island. This is a relaxing incision to relax the TPF So that when we pull on the edge of the wound, the tension is transmitted to the skin to tighten the temporal skin. See now, when I'm pulling, the skin is much more tense because they expanded the skin.
It'll be held up by the TPF. See how it's expanded by like almost a centimeter, right? Oh, yeah. You see that? Yeah.
Okay, now we've done the suspension of the cheeks. Now we're gonna just push sutures to the distal part of the incision here, so that we're not gonna tie it just yet, because we want to maximize the rotation of the temporal skin and the brow, so that it's in a matter of a vector that's vertical and central, what we call Fabergé vector. So this is our cable suture, taking the TPF on one side of the temporal incision. That's a TPF. I'm going to pass it through the incision here, in the perimedian incision, across to the other side. This is a free-floating suture for the other side. And then we're gonna take the TPF on the other side. Okay, so that's very clear. Right there. Okay, so that's one, the cross cable for the temporal incision. Now we're gonna do a cross cable for the perimedian incision, taking the galea on one side and passing to the other side. Okay, passing to the other side. And then we're gonna take the galea on the other side. Okay. So here we go. Okay. That is now tagged. So now we're gonna tie these sutures, but my assistant is pulling upwards on the two temporal incisions on each side, creating a rotation and tightening of the temporal skin. And then they're gonna do the same thing for the perimedian incision. Once that's tied, and here's the perimedian incision. Let's pull up and then cross. Once that's tied, the brow is secured, is rotated, and then also the vector is in the medial, vertical central vector is a Fabergé vector, like an egg. Then finally we tie the temporal island suture that's been previously tagged, so to tighten the temporal skin. So we want to prioritize the vertical central vector first, and then we set the lateral vector for the temporal skin. So the vertical central Fabergé vector is the priority. And finally, we're going to close the incision, and this is the last push for the progressive tension, taking a bite of the incision on the downside and taking a bite of deep temporal fascia further up to get that last bit of elevation of the temporal skins. So here's, see, taking the skin edge on a TPF, the scalp edge rather, and taking it further up on the TPF. So when we tie this down, there's going to be even a little bit more displacement, vertical lift of the temporal scalp. We'll tie that. So the funny thing about this surgery, that this cable suture is an integral part of the surgery, the suspension. They're not just regular sutures for closing. These are really suspension sutures. So then once everything is done, we have now set the foundation with the face, the position of the brows, the eyes, and cheeks. Then we're gonna do fat grafting in the forehead area, in the brow area, subbrow area, lateral cheek area, a little bit of cheek, nasal fold, lips and chin point, chin groove, and so on. So in this patient, we injected 67 cc's, and this is a fairly average. Let's see how much tighter this is compared to before we went upstairs. It's much tighter now. You see the difference here. Once we have completed the vertical suspension of the mid face and the lateral face in a deep plane, the platysma and the smash becomes much tighter without us doing anything else. So this is before we do the posterior corset. So we're really tightening the whole deep system, from the top of the head to the bottom of the neck. So now we're going to do the posterior corset. The posterior corset is taking the lateral edge of the platysma muscle, and we're going to tie it back to the masseter fascia and the posterior fascia of the neck. This is important because it really creates a narrowing of the circumference of the neck to make the neck long, skinny, and tight. I don't do any kind of a strip to reorientation of the smash strip to the posterior fascia, or I don't do any crevasse work to create a gonial angle. I simply do this to create a narrowing of the neck, and that alone will create a sharper angle of the jaw, and and really tighten the jaw. So this plication goes all the way down to the top of the posterior triangle. You don't want to go lower than that, because if you go lower than that, then you'll get some webbing of the neck as they turn their head. So the inferior limit of that plication is the top of the posterior triangle. Okay, so once we've done that, so this is our, what we call a posterior corset. We're gonna run, those are interrupted 3-0 vicral sutures, and we're gonna run another 4-0 vicral suture along that edge to make sure we have that very secure. So once we've done that, the posterior, the neck is very, very tight, is fully tightened. Okay, so we're gonna run that up.
We're now
So
6
then
weeks
we
exactly
close,
today,
we
right?
close
Yes.
After
the
going to a
neck.
facelift. What do people say when they see you?
They tell me that I look 62 and now I look 45.
Remember, I told you it's gonna be 20 years, right?
Yes, and they think I look like many years ago when I used to go to college.
Wow, okay, that's good. So we got some swelling still, just in the lower face area, but the jawline looks good. Hair line looks good. It's going this way. Your eyes looks beautiful. So I'm just waiting for the swelling in the lower face to get better, but you look really, really good. You're what I call plan A. So we're hitting toward a home run, so.
Good.
All right?
Yes, looking forward.
Thank you so much.
Thank
So
you.
This is her, like, I think 4 weeks after surgery. Obviously, there's still swelling, but this is her 6 weeks post-op here. In photos, you see the improvement in the position of the brow. The upper eyelid skin has been, hooding has been treated. The lower eyelid infrabrow area is full, and the cheek is much improved. The mid face is improved. The neck is certainly improved. Canal view looks good, although still swollen at this point. 6 weeks post-op. And you see the neck the hyperdynamic neck platysma muscle, and she's trying to contract that post-operatively 6 weeks later. She can't because everything is tied down. So when you tie it down, the platysma band is handcuffed, so they can't really move it all that much and sort of improve that dynamic band problem. Thank you very much.
Okay. Thank you so much, Dr. Cow. Masterful as always and expected.
Thank you.
So we've got questions in the chat box, and I'd encourage everyone to go ahead and add any more that they have now. And I'm going to go through some of them. And in the meantime, in a minute or two, my colleague Stasia will put some poll questions in, and then we're going to grill you about the answers and see if they're as anticipated. So let's just dive right in here. The first question we got was from our dear friend Val Lambros, and he was asking, how long does the procedure take?
That's a very good question. You know, everybody thinks that the procedure, because the endoscopic take a long time, but actually the endoscopic portion, the mid-phase endoscopic portion is about 4 hours. What takes the most time is the neck, submandibular glands in the neck, okay? And then, so we're working from the bleph, the upper, lower bleph. This is a panfacial rejuvenation. So, and also we do our procedure with only IV sedation. It's not under general anesthesia. So to me, it's a much more natural way of sleeping without challenging the physiology too much. And so the procedure took us about like 14 hours or so. But the way that we run anesthesia is interesting because during the active part of the section, which we have to go slow, of course, to do all that dissection, is under only IV sedation. But once that's done, the rest of the suspension and the sculpting and the fat transfer doesn't require a lot of anesthesia at all. So we turn it almost off. So they're kind of sleeping it off as we do the sculpting and so forth. And so at the end of the procedure, we time it so that when I throw my last stitch down to wake up, they're ready to go. So the day is long, but the amount of anesthesia they get is actually not as much as you think.
Fantastic. Hopefully that, Dr. Lambros, if you're still on with us and have any follow-up questions, let us know in the chat box. Next up, Dr. Prashantha Kasari is asking a couple of questions. First, how and at which step do you place the tear trough implants? And then how do you manage if there's a fold of skin in front of the ear at the end?
Oh, that's a good question. So in terms of tear trough implant, when during the step of my procedure, if I'm going to do that, then it's during the mid-face dissection, because I'm right there coming down along the dissection mid-face. The orbital region is right next to it. I'll just find the superior occiput plane and make the pocket exactly the size of the implant. And I actually customize the implant so that I make sure that we don't change the width of the cheeks and so forth. And we actually customize the implant and we make the pocket exactly the same size as the pocket, as the implant. And we slip it in endoscopically. And then we close the little window opening. And then that implant just sits there, does not move, does not rotate, doesn't do anything. And it just fixes itself. Doesn't need any fixation. In terms of what was the second question? Sorry.
What do you do if there, or how do you manage the fold of skin?
Oh, the fold in front of the ear.
ear?
Yeah. So a lot of times, if there's fold in front of the ear, depends on how bad it is. Okay. So if I can get rid of the fold with a little fat transfer, I would say probably 90% of the time that solves the problem. Okay. Because it's sort of like unsupported skin. But if it's really kind of bad, it looks a little unnatural, then I have to extend the incision up a little bit. It could be just perilobular or Did I lose you?
Nope, we're here.
It could be just pure lobular, or it can just be a little extending up just around to the top part of the tragus, or fully. If it's really a lot, then it'll be in the root of the helix. So it depends on how much redundant skin or problem there is. So that becomes what I call ponytail facelift type 2.
Very good. Thank you so much for that. Now, Santiago Lozano is asking, besides the logical effort to enhance symmetry and suturing, are there any tips and tricks?
The logical,
I guess trying to achieve symmetry.
well, I think when the face is asymmetrical from just naturally asymmetrical, right? Usually one side of the face is wider and shorter, the other face is longer and skinnier. Okay, so usually the left side of the cheek is higher. So when you put a cheek implant or something, you have to accommodate for that. So to accommodate for asymmetry, once we put the cheek in place and everything else in place, then we use a lot of fat transfer to equalize that to camouflage a lot of asymmetry.
Let's see here. Going down the list, Osama Samagandi is congratulating you on a nice presentation and asking about your approach to buccal fat reduction.
Oh, that's a great question. Thank you so much. So the buccal fat reduction, I do it sparingly. I don't use it much at all because I prefer to lift the buccal fat rather than reducing it, for the obvious reasons of later in life you lose volume in your face. So I'd rather lift it than reducing it. Having said that, if there's somebody who's young, they really have a cherubic looking face, I really want to thin out the lower face area, I can either do it through the deep plane dissection. Laterally, I can tease the buccal fat out, either resect it or redrape it, or I can go intraorally and get that.
Okay. Next up, wow, we are blowing up here. This is fantastic. Let's see here. Zara Karbasi is actually, she was asking about buccal area as well. And do you connect that to the mid-face flap?
My buccal fat.
Buccal, how do you work on the buccal area and do you connect it to the mid-face flap?
No, I mean the buccal fat is deep, and then I'm pre-periosteal. I mean, I'm sorry, I'm sub-SMAS in that area, so I'm above the muscle, and the buccal fat is below that, so I do not connect the two.
Okay. Christina Rosati is saying PTF suture 3.0. By placing a transfixion suture, is there a risk of leaving a visible dimple? I think you kind of addressed that, but you can maybe recap. And then how can you manage it?
Okay, so when we put these, I think she's asking that when we put these sutures in the cheeks, you can't get dimpling, okay? So this is something that you have to use a little artistry with it, because what I learned in my first day of residency, my attending, we were doing a breast reduction, and I was general surgery trained, and I'm doing the closure. It was a perfect closure. He looked over, he cut my suture out, and I was shocked. I said, "What do you do that for?" He said, "Do it again." I said, "Why?" He goes, "Do it again." So I did it again, exactly the same as before. He goes, "That's better." And then he says, "No stitch is sacred." Okay, so no stitch is sacred, meaning that if it doesn't look good, you take it out, do it again. Okay, and then so you can minimize the dimpling. And a lot of times, you know, it's still there. So how you manage that, you can do a little subcision and fat transfer with it.
Okay, great advice. Love that. Andrea Pio Casino is, I'm sorry, hold on. Let's mute somebody here. Okay, sorry, okay. So Andrew's asking, which is the donor site for fat grafting? Do you use a specific cannula, and in which plane do you inject? Oops, I think you're muted, Dr. Cow. Sorry, I think I might have muted you.
You did.
Sorry, okay.
Okay,
my-
so the best the cannula I use is I use a tulip. It's a harvesting cannula. Is 3 millimeter with 1 millimeter side port. That's how I use to harvest, and then I inject with it as well. The location of the harvesting, I use the inner thigh a lot because and then also the knees. The fat there is a little bit less fibrous, so it's a little less problematic when it comes to lower eyelid cheek junction area. Lower eyelid cheek junction area, I'll put some microfat deep along the orbital rim, and also a little superficial just below the orbicular sarcoid muscle with nanofat.
And did you say the donor site for fat grafting?
Do I say what? Sorry.
What donor site do you use for fat grafting?
Oh, I said inner thigh or knees a lot. And then the abdomen, I don't use quite as much. It's a little more fibrous, especially the upper abdomen is more fibrous.
Okay, very good. And let's see, Peter Robluski is asking if you have residual medial platysmal bands, do you redo the neck through the submental incision or behind the ear?
Residual platysmal bands. If I really have to do it, I'd do it through the central, probably.
Okay. Alan Wilk is asking, what do you do with dimples? Well, I think which are present even at the close of the case. Okay, maybe if you can address that piece.
Dimples, again, subcision and a little fat grafting on top of the subcision.
Okay, I'm going to launch our first poll here. Hopefully everyone, can you see that, Doc? Yep. Okay, I see the people responding. Okay, meanwhile, Dr. Wang is congratulating on a fantastic lecture. And did you transect the platysma or did you only suture?
Okay, the question is, I'm trying to find my plugin. Okay, so can you give me my things? I'm trying to plug my computer here. So in terms of platysma band transection, is that what the question is?
Yeah.
Again, I do a back cut after I placate the central platysma bands. Then I do a back cut as low as possible, about 2 centimeter back. I do transect a little bit. I don't do a full transection like Mario Pella used to do.
Okay. Sorry, I'm just trying to get the polls coordinated here. Oh, right. Mohammed Turek is asking, how do deep temporal fasciae hold this much of sutures, and have you faced any problems with it? Also, how to ensure bilateral symmetrical lifting?
Okay, so the question is the deep temporal fascia, how does it hold so much sutures? It does. You have to kind of, when I start suturing the level 1 sutures, I put it a little lower, and then as the level 2 is a little higher and higher. So I try not to go over too many places on that one over that one area, because you will tear up the deep temporal fascia.
Okay. Now let's see. Matthias Tremp is saying, is the technique also suitable for severe lower face / neck laxity with advanced jowls, pronounced malartosis, and deep nasolabial folds?
Yeah, so I know when I was in 5 years ago, even when we first started talking, when I first presented this technique, the misconception is that this technique is only good for younger patients. That's why but actually an older patient, it works well as well, but we have to make sure that we can still do it without the incision in front of the preauricular area in most patients. So over the years, I think as I gotten better with the vertical displacement of the skin flap vertically, then I have a less need to extend the incision in the front, because when you take the incision in the back, you'll gather some in the front here, then we can displace it up this way. This is why we don't have to cut in front of the ear. So as we got better, be able to pick that up vertically, we don't have to cut in the back to extend this as much in the front. So over the years, we've gotten better not to have to do that. In older patients, we can do most of the time with the ponytail facelift type 1. But of course, when patients have so much skin, or some patients have that, what I call bubblegum skin, that just kind of keeps stretching. When you have like a lot of dog ear, or even people have a lot of like right tits in front of the ear already, and when they pull it up, it misdirect and make those look funny. We just have to flatten that out, okay? But the incision there, even have to make the incision, it heals up very well because we don't do any kind of tension. Is that we don't do any dissection through it. There's no tension or closure at all.
So how long did it take you to perfect this? Because I know you said when you got better at it. So how long did that take? What can people expect?
It's always you know, we've been doing, I mean, I've been doing this procedure for the last 25 years, you know, and it's really about solving problems, problem solving, you know. When you first started out, you know, you're trying to perfect the brow and the brow area and the eyes, and fat transfer become a very important part of that contour and shaping, and then becomes the oh, what do we do with the lower face and the neck? And people come in with these problems. How do I do without the incision in front of the ear? Then we solve that problem, and then thanks to like Andre and Francisco and Gerald Daniel, and then also of course Timothy Martin with a deep neck stuff, I adapted to that, and that helped the neck contouring a lot. Okay, so that helps. And then so then now so it's always constantly evolving, right? So now the last frontier really is really trying to lift the cheek in an effective way. The mid face is the magic to beauty now. You know, I know Francisco, my buddy, says that the neck lift is a new facelift.
He loves the neck, right?
Right. And I love Francisco, and he's my friend, but I beg to differ from him. I said that the mid face is the magic to the new beauty of the face. So really, we have to focus on the mid face because a lot of what we do, what I see with the deep line facelift, high smash, it doesn't get into the cheeks very well. It doesn't get into mid face very well. And also, there seems to be a little misconception or confusion what the mid face is. Some people look at the mid face as the lower eyelid cheek junction area. After that, they say, "Oh, the mid face is improved," but in reality, the nasal lobe full hasn't changed. So it's really the mid face is really both the lower eyelid cheek junction and the nasal lobe full, and maybe in the marionette and corner of mouth area. So this whole area is really critical in rejuvenating, also beautification of the face.
So speaking of Andre Oswald, have you or do you use the A-net, and do you do it in combination with your facelifts?
I have never used the A-net because I think there's reasons. I think Andre is brilliant in being able to come up with solving a problem. The problem is a hemostatic net, meaning that it is a dressing postoperatively to prevent a hematoma, right? And he solved it very effectively. And the reason why there's a significant incidence of hematoma in facelift patients is that because you're really delaminating the skin, so you're cutting those little capillaries from the fat to the skin. You're really cutting those vessels, and they can't bleed postoperatively when you have a letdown from the epinephrine in the recovery room, right? So that's a problem, and Andre solved it very, very nicely with that. In our dissection, we're in a deep plane. It's a natural plane of the face. It's a glide plane almost, so that there's not a lot of vertical vessel that goes through there from the muscle to the subcutaneous fat. So we're in that plane that's relatively avascular. And then we see the vessels that are going up, and those are vessels in the temporal area, be the sentinel vein and the little vessels from the medial lateral zygomatic-temporal neurovascular bundle. Those little vessels, we go around it. So we don't have a lot of bleeding per se. So we don't
Okay,
have a lot of
great.
inlet.
Got it. All right, 17 more questions. So are you ready? I'm going to just rapid fire them at you. Let's see. We've got an Austin from fellow. I'm sorry, a fellow from Austin named Juliana Zenke, who's wondering about how you address the earlobe and what specific considerations you have.
How do I address the earlobe?
Yeah, I'm not sure. There's not more detail there, but
Well, with this procedure, the incision around the earlobe is variable. When you have displacement this way, and it's all displaced, we try to move the skin back this way, and it's complete displaced, and the earlobe sits in a neutral position. That's great. We don't have to do anything around the earlobe. Sometimes we pull this back this way, posteriorly, the earlobe gets pulled back a little bit, then we have to release the earlobe and set it back down. So that's a perilobular incision.
okay, let's see. Carlos Rivera Serrano is asking if you can summarize how you protect the frontal branch of the facial nerve in the lateral temporal area. Specifically, do you release the zygomatic arch, or, as it seemed in the video, completely release the lateral 2/3 while leaving some medial attachments between the malar bone and temporal fascia where you dissect with the scissors?
That's a great question. So, yes, the frontal branch of the facial nerve is could be injured along that pathway, either coming out of the parotid gland, becomes more superficial in the superficial temporal fascia. So when you're dealing with that area, taking down the zygomatic arch ligaments, you're safe in the lateral third. But the medial third, you have to be careful to do a little gentle dissection and spreading there. And I would not do more than go deeper than just the superficial, the superior zygomatic arch. Also in the temporal area proper, when we're doing the dissection there, we have to make a little smaller spread of the scissors so you don't get any kind of trauma to the frontal branch that's above you in the roof of your dissection.
Very good. Let's see. Louise Melky is congratulating you on your beautiful dissection and results and asking if you have long-term results that you can show and how do you advise patients on this?
Okay. Yes.
Read the ASJ article.
Yeah. In the article, we have long-term follow-up. There were 17 years follow-up. We do have good long-term follow-ups, and that's not presented in this look-like video, but yes, we do have long-term follow-up. And people ask me all the time, well, how long does this last? Does it last more than the deep plane facelift or high smash facelift? And I would say yes, because I've seen it in my own patients, but also, when you think about it, we're tightening the face from the top to the bottom of the neck in a deep plane. You can see how tight the neck is when we're finished, right? And so, and also we are tightening the cheek, the mid-face area in a deep plane as well, which a lot of the traditional facelift doesn't really address the mid-face. So we really are comprehensive in our total preservation deep plane rejuvenation.
Okay, now let's toggle over to someone with a heavy neck, post-bariatric patient. Andrea Pio Casino saying, how do you manage the excess of skin? Do you ever perform skin reduction in the middle part or liposuction?
Okay, so first of all, in terms of liposuction, the segmental area, I don't like to do liposuction there because of because you end up sort of removing the support for the skin, especially for women. Okay, so what I do with the dissection there, I dissect the subcutaneous fat and the skin off of the platysmal muscle very cleanly. Then I tighten the muscle, do my muscle work, go do deep anterior neck work. And after that, if there's still fullness there in the segmental area, I would plane it directly with scissors. I want to keep that flat very on a thicker side and without any kind of problem with streaking or dimpling of the skin. In terms of massive weight loss patients, I mean, the skin is the skin, right? You have a lot of excess skin, you're gonna have to remove it. So either that becomes a ponytail facelift type 2, where they extend the incision up here to remove excess skin there. Or, and I can tell you, we've done, also have had experience with weight loss patient with massive weight loss, and our incision never goes, ends up right here at the root of the tragus. No matter how much skin there is, we never go around here and go up in the temporal hairline at all. So the upper limit, the most we ever extended incision is only at the root of helix.
So no liposuction. Is that
I don't like to do liposuction in the neck.
okay? Got it. Goretti Tagba is asking, in a traditional endotine ribbon mid-face lift, the ribbon is placed in the periosteal plane. In your ponytail lift, the ribbon is placed more superficially. How do you ensure there's no injury to the zygomatic muscles and nerves?
Okay, so a traditional subperiosteal mid-face dissection with the endotine mid-face, not ribbon, mid-face. You can put ribbon there too, but the spikes are too shallow for that. But that's where you place the ribbon. In our dissection is pre-periosteal, right? So we're actually above the muscle of the zygomatic major. So remember, when we're dissecting, we're on top of the Z major, so we're not injuring the Z major at all.
Perfect.
And our ribbon is in the sus mass, if you want to say there is a SMAS in the area. That's very controversial. And then we're above the muscle. Thanks, Leonard, if you're listening.
Anupama Chowdhury is asking if you ever do micro liposuction on heavy jowls or nasolabial folds.
I have. It's not my favorite thing to do, but let's say the jowls. I don't do liposuction of the jowls. I just directly plane it with scissors. Okay. Again, I don't like the irregularity of the liposuction of the subcutaneous fat. And then in terms of nasolabial fold, I would say never. I don't think I think I maybe done it once because somebody's just so much hanging over. Okay, so that's like the last resort. My algorithm for treatment of nasolabial fold is to augment the bone and then to lift the cheeks in a deep and also superficial layer.
Okay, I'm watching the clock here. Do you have exactly 10 more minutes? Because we have 8 questions. We could probably get through all of them. Do we have a hard stop at 1:30?
Yeah, sure.
Yeah.
I have to go back to my course.
I know, you have to go back to your day job. Okay. Chatpon Kong Fang Feng is asking, he sometimes does your technique, sorry if I butchered that, and he's getting bunching around the orbital area when he does suspension. Do you have any advice?
Bunching the periorbital area when he does suspension in my technique?
He's saying, I got bunching around the orbital area when I do suspension. Any advice?
And he's doing the same dissection as me?
Says I do your technique and sometimes I got bunching around the orbital area when I do suspension.
I'm not too sure because that's not my experience, but I'm guessing that he has not completely did a full dissection of the periorbital area. It has to be widely dissected, and then you have to watch out for the sentinel vein and medial and lateral neurovascular bundle. Complete redraping of the area will get rid of the bunching.
Okay. And I guess people can write to you, right? I'm supposing that if they have questions beyond this, they can actually approach you if they're there live with you, or otherwise write to you. Dr. Cho is asking if he's able to use your ponytail lift term in his practice. I'm not sure to what extent, so maybe think about that one. We can see if he wants to explain a little more.
Well, let me just explain that a little bit. So that ponytail term is a trademark of mine. And I think that of course, people want to be identified as using this technique. However, I think that in order for me to really, I think in order for me to able to let people use it, they have to perform it in a very capable way, right? Because otherwise they give them the term and the technique a bad name, right? So
Does that mean they have to be trained by you, maybe?
they have to be trained properly, yes.
Okay, that's fair. He's also asking, do you ever add laser resurfacing, example, CO2 at the same time?
Absolutely. We always do a laser resurfacing or a 15% or a TCA peel based on their skin type. So you have to address 3 layers of the face in a modern facelift. The deep smash layer, the subcutaneous layer, and with fat transfer, and then this resurfacing for the face.
Okay. What about the male brow? Andrea Casino's asking, do you have a different suture pattern for the brow tail?
Oh, that's a good question. So we are actually, Phaedra, you'll be happy to hear this, but we're actually writing a manuscript for ASJ. Our next
Fantastic.
paper is coming. We're going to submit a manuscript, and it's going to be called brow fashioning. So brow is not just lifting, it's shaping, right? So
Okay.
for male brow is now you cannot lift it up. It's more of a lateral displacement, or it's a minimal shaping of the brow. So you have to be conservative with a male brow. Okay, so there's different shapes of the female brow that we can create endoscopically based on 3 things: the variation in the dissection of the glabellar region, number 1. Number 2 is the amount and the location of the cable sutures we use to suspend the brow, number 2. Number 3, it is the pattern or the sequence of the tying of those cables. Those 3 things together, we can manipulate the shape of the brow in an endoscopic manner.
Great question. I'm glad we got something in there about the men, since we're probably predominantly on the one. Oh, you've got a little heart there. What percent, Dr. Wilk is once again asking, the percent of temporary temporal branch paresis of the orbicularis paresis?
Orbicularis or frontal branch?
What is the percent of temporary temporal branch paresis? And then he says of orbicularis paresis.
I think that the frontal branch temporary paralysis is usually it's around I think it's around like 5% or so in our publication, and usually is never permanent. It goes away in 6 to 8 weeks usually. If that happens in an asymmetric manner, then you Botox the other side. By the time the Botox wear off, the other side has already catched up.
Caught up, okay. Dr. Anderson is asking about the most common complication that you've seen in your patients, and have you had patients whose sutures have come loose, and how do you resolve that?
Usually the sutures are there just to be anti-gravity, and when suture come loose, it doesn't really matter. If you go back, I've gone back in some reasons for other reasons in the same area, the suture are already loose. So it's really the suture is really anti-gravity, and then after a week or 2, the tissue healing glues that the cheek or the temporal area in the right position. So the suture really is non-functional at that point.
Okay, we've got 2 questions, and we've got a hand raised. Did you want to let Leonard unmute here? Let's see. Leonard? Are you with us? Okay, we'll wait for him to come on. Dr. Ayuzkan is asking what advice you would give to beginner surgeons.
Oh, well, that's a good question. I think they will have to learn endoscopic. They have to take a course from either the offer the American Society of Aesthetic Plastic Surgery, um, or other. We have a course that we put together. We're at University of Pittsburgh right now. Those are two, one beginner, one novice course, and then we have advanced course coming up. But the key is this: is that you have to have the desire to learn. You want to learn this. You have to have a commitment to learn, and then you have to have a good uh, a good good instructors, a teacher, a mentor to teach you, because it's not an easy operation to learn. There's a lot of complexity to this operation, but it's completely doable. And just today, we had we did a course yesterday, and then the participant said to me, you know, I used to think this is such a mystery. I didn't know how to do it, and then now I come out with this course that I think I can actually do it. That's great, because we take it step by step into to the dissection of this area.
And that aligns with about the 40% of respondents to the poll that we asked, how likely are you to try this procedure, in your own practice? And roughly 40% said yes. So I think
They said they're willing to try it, 40%?
yeah. Okay, last question from the chat box. Then I have one question / wanted to give you a moment to talk and kind of sum up for us. But Dr. Pataki is asking, why do you use tear trough implants if there's fat grafting to the TT?
Tear trough, right? Okay, so I love that question. Thank you so much. So what happens with aging, and also congenitally, you can this happens that people have a large orbit. Like when you're aging, Val Lambros knows best. This midface area, the bone, you have bony reabsorption. The orbital hollow becomes, the orbital bone expands, and the midface retracts and collapses in, right? So it's a bony problem. So when that happens, the cheek falls down, and then when the cheek falls down, it thins out the orbicular sarcoid muscle, and the orbital content falls out, and then you have bags that shows up. Okay, so when you're trying to do just fat grafting in the tear trough area, you're asking the fat to do a lot to fill that whole area in a large hollow orbit. Where it, first of all, it can go away. It's unpredictable. It could have lumpiness. You're asking the fat to go do a lot. Okay, so my solution to the area is actually is multifaceted. So we have to treat the bony defect with a tear trough implant, and then we're gonna pick up the cheeks, and then we're gonna add. Then we're gonna tighten the skin a bit with a lower blepharoplasty, and then finally we're gonna fat graft a little bit on top of that. So to fill a big area, instead of trying to ask the fat to do everything, we have little things that fills in. So the amount of fat, so we're gonna be like using 80% of the result from the tear trough implant, and then 10% from the cheek lift, and then the 10% from fat transfer. So we're not asking any procedure to do a lot, so that we don't have problems with anyone.
Excellent. Now, I had a really nice set of questions, but since we had 30 or 40 from the chat box, obviously I prioritized them. But you're there at the Ponytail Academy. What else do I need to know? I'd love to give you an opportunity to tell us a little more about the Academy for those of the attendees today that are not there with you live in person. Tell us a little more about the Academy.
Oh, thanks. Look, this is actually, we started doing this because we have so much requests and so much interest after the publication. And people are always asking me to come to the OR and observe me doing surgery. And I'm always a little hesitant to do that, because people have come and they take a selfie with me and say yes, and then I'm here with KO, and then they go home, they do they do try to do the dissection and doesn't turn out well. And I have to respect the name of the what we created, because it has to be a good procedure. A good procedure has to be something that's reproducible.
Mhm.
That I cannot be the only one who can do it, right? It has to be reproducible. And also, my mentor says to me that if you don't, is Yuri Chen from Taiwan, a craniofacial surgeon, he said, if you don't teach it, then you'll die with you. I don't want to die with me, right? So I have to teach it, and I want to teach it in a very, very, very good way, because I want my colleagues to be able to do this and have really, really good results. So that's what the effort is in this academy. See all these little things back here. These are 20 stations that we have here, that each station Endoscope is broadcasted on the screen back there. So the way I do it is that I do the dissection, they observe it, they go back to the station, and they do it, and I'm monitoring the screen. I can see who's in trouble. So I see somebody's in trouble, I go to the station, I said, all right, give me channel 4, table 4. Then I can say, okay, this is what happened, this is how they got in trouble, and this is how we get out of trouble. It's a teaching point. So the academy, we've done this. This is our second year at University of Pittsburgh. And I think is getting better as we develop more ways to teach it. And it's a commitment, and we have to teach it right.
It sounds like this is your legacy, and it's exciting for everyone who's along for the ride learning from you. So thank you so much. With that, we'll let you get back to your actual Ponytail Academy. Thank you for being here with us. Thanks to everyone who attended. I did put a few links in the chat box to our annual meeting in Boston. We've got Face and Rhino. We've got a journal club coming up, and lots of other things. So we hope you'll take a moment to check those out. Dr. Ko, we will see you next time, and thank you so much. Have a
Thanks,
great rest of your
Phaedra.
day.
Thanks so much. Give me an
Take care,
opportunity.
everyone.
Bye-bye.
Bye-bye.